Hello, everybody. Welcome to the first installment of Ethics Grand Rounds for the spring semester. My name is Deb DeBruin. I am the interim director of the Center for Bioethics, and I'm really happy to see you all. A couple of reminders before we get started. If you are a biomedical engineering student and you want credit for attending this session, there is a sign-up sheet in the back. Please make sure you sign up on your way out if you didn't already sign up on your way in. Ethics Grand Round sessions now also qualify for interprofessional education credit for health sciences students. So if you are, there we go, interested in IPE credit for attendance at this session, you can see an email address here to send a note to that effect, and we will make sure that you get the reflection exercise that you need to complete and then that you get logged for credit. If you have any questions about that, also feel free to just send a note to that address. I also want to thank our co-sponsors for this event, the Masonic Cancer Center, the Division of Health Policy and Management in the School of Public Health, the Hubbard School of Journalism and Mass Communication, and the Women's Health Research Program. The Center for Bioethics really aims to build connections across campus, and we really appreciate the partnership of all of those programs. So without further ado, I'm going to introduce Dr. Sarah Gollust to you. Dr. Gollust is an associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health, and she's an affiliate faculty member of the Center for Bioethics. She's also an associate director of the Robert Wood Johnson Foundation Interdisciplinary Research Leaders, which is a national program based at the U of M that supports community-engaged health equity research. Her research examines the influence of the media and public opinion in the health policy process, the dissemination of research into policy making, and the politics of health policy. She's focused this research agenda on a range of timely topics in public health, including childhood obesity, cancer screening, and the Affordable Care Act. Her research has been funded by the National Institutes of Health, the Robert Wood Johnson Foundation, the Russell Sage Foundation, and the American Cancer Society. She's here today to talk with us about communicating about breast cancer overdiagnosis. Please join me in welcoming her to Ethics Grand Rounds.
Thank you so much. Can everyone hear me okay? Okay, I think that's a yes. Great. So thank you. I'm really excited to get to share this research project with all of you today. But I also hope that we can have a discussion about some of the themes. So I will pause periodically and invite any reaction or discussion. If we get a little bogged down in conversation, I might move us along so that we can also make sure we have enough discussion time at the end. But that is all to say, if you have questions of clarification, please feel free to interrupt me. I don't mind at all. So I just want to acknowledge the many, many people who have worked on this project to date. This project was funded by the American Cancer Society. It was a 4-year project. It ended last year. I want to acknowledge OACA. She is in the audience. Also Abdi, who unfortunately I neglected to even put on here because she's my most recent collaborator on this project, just started a couple months ago. And so this is the result of a project that was a 4-year research scholar grant from the American Cancer Society. So I wanted to start by telling you a little bit about me. So I'm a social scientist, I'm not a clinician, and I'm not an ethicist in any sort of professional certification way. What I do is I study the intersection of communication and health policy making. So I'm fundamentally interested in what drives health policy decision making, both among the public, how the public think about health policy priorities and public health issues, as well as how policymakers do, and how media coverage and public opinion shape the policymaking process. So my research training is in health policy and health communication, and I've also drawn extensively in sort of my graduate degree and postdoc in political science and sociology. So I just wanted to situate sort of who I am and what my perspective is as I move into talking about the issue of breast cancer screening related communication. So as Deb described, I've focused on many different issues in understanding this sort of machine image that I showed on the previous slide of the intersections among politics, policy, and communication. And so one of my interests in breast cancer screening, ironically, was actually spurred by research that I did in the obesity context, particularly around policy and regulatory strategies to address consumption of sugar-sweetened beverages. So in this work, I was interested in how the issue of soda tax and other regulatory approaches to address sugar-sweetened beverage consumption are portrayed in the media, how the public thinks about those issues, and how they might respond to messaging around sugar-sweetened beverage taxation. And what I find, and I describe in the article you can see on the left side of the screen, is that the information environment around childhood obesity is characterized by a few different features. So one is that it's politically charged. So we looked at news media coverage in TV and print, and we found sort of abundant messages about what Republicans think about soda tax, what Democrats think about soda tax, and that got us to thinking about what happens when political cues or values-based cues are in the media. How does that affect the way the public thinks about those policy solutions? And what we found in this work is that in the conditions, communication conditions around this public health topic where there's a lot of messaging on both sides, so pro-tax, anti-tax, Republicans say this, Democrats say this, we found that those are the conditions in communication that create a ripeness for potential backlash. And that's what we observed with soda tax. So we saw that in areas of the country where soda tax conversations were more prominent, where there was more exposure to this messaging in a national survey of over 5,000 individuals where we were able to segment by what part of the country people were in, we found that there was polarization in response to messaging about soda tax where Republicans moved in opposition to a tax when shown information, whereas Democrats and moderates moved in a pro-tax direction. But what you saw on average was a mixing, right? So no effective messaging about soda tax, but what that hid was actually, what it masked was variation in this idea of backlash. So I have been very interested in this idea of backlash to public health messaging for a while. And that really brought me to understand this context of breast cancer screening for women in their 40s. So the question that motivated this project was, as I did with the childhood obesity and the soda tax context, was first, let me just describe the information environment. What are the messages that women might be hearing about breast cancer screening, particularly guidelines around when to initiate screening and how frequently to engage in screening? What does that look like in the media? And then how might women respond to those messages when they encounter them? And I want to clarify that this is not communication from doctor to patient or from clinician to woman making the decision about getting screened or how frequently to get screened. This happens before that. So I'm interested in the context of women's incidental exposure to information about breast cancer that happens well before they might even think about the clinical decision that they face in the clinic. But I hope you share my interest that matters, right? So what women are exposed to, the social context, the media context surrounding breast cancer screening really does matter when they reach an age where they need to consider when and what frequency to engage in screening. So the goals of this project, and again, this is a 4-year project. There's massive amount of data collection. I'm going to focus us a little as we walk through this. We're first to characterize the information environment about breast cancer screening using the method of news media content analysis. Second, to estimate women's awareness of breast cancer screening related information, particularly the potential harms and the potential benefits, using surveys. And then finally, to evaluate women's response to media messages about public health guidance around cancer screening using a tool of a survey-based experiment, which essentially simulates exposure to information by, in an experimental context, showing women certain versions of news articles and then asking them survey questions after that. So this context it's important to get a little bit more clear on what we're talking about here. So many of you are probably aware that for women in their 40s, there are different guidelines depending on which professional society is issuing that guideline on at what age women should begin routine screening. So this is not for women with a family history of breast cancer or a genetic predisposition for breast cancer. But for women without those particular risk factors, there's different guidelines on when screening should happen. So you can see on the left, the American College of Radiology recommends annual mammography for starting at age 40. The American Cancer Society recently, actually almost 5 years ago now, updated their guidelines to recommend that most women consider initiating screening at age 45 and then do that annually until age 54 and biennially every 2 years thereafter. While as the U.S. Preventive Services Task Force, starting with their guidelines that they issued in 2009 and then updated in 2016, recommend routine screening beginning at age 50. So at the same time, there are competing or conflicting recommendations out there. And the reason for these different guidelines is a question of evidence. It's a question of different evidentiary interpretation across disciplines, sort of what clinical discipline, and across perspectives on society and individuals. And so this is a sort of classic tension in public health or public health ethics, where you can focus on an individual and an individual patient's decision making, and then there's also simultaneously a population level weighing of the distribution of risk and the distribution of benefits. And so these different and conflicting guidelines come from different weights put on the potential benefits of early detection and treatment and the potential harms accumulated over the population on women receiving false positive results, receiving a result that wouldn't, for a cancer that would be indolent or so slow growing that it wouldn't harm that particular woman in her lifetime. And that's a concept called overdiagnosis, which is really at the crux of this conversation. And then, as I mentioned, that difference between taking an individual perspective, where every single woman who has a screen-detected breast cancer should be treated, and then the population perspective that recognizes that on aggregate, like any screening technology, the more you screen, the more likely on average you are to identify population-level harms or risks. And so I wanted to identify the specific definition that NCI, the National Cancer Institute, provides around overdiagnosis, because it interestingly highlights this sort of epistemological and evidentiary challenge related to overdiagnosis. So I captured this as just a silly screen grab straight from the NCI website, which defines overdiagnosis and resulting treatment of what they call insignificant cancer, so cancer that would not potentially go on to cause life-threatening harm. Some screen-detected cancers are life-threatening, others are not, with no definitive way of discriminating between them. So they recommend that cancer therapies, including surgery, radiation, endocrine therapy, chemotherapy, and therapies targeting the HER2 receptor, are recommended for all cases, even for patients who will gain no benefit. So it's a really interesting, from we're thinking about this as a communication perspective, how is the NCI communicating this nuance around screen-detected breast cancers that might actually not benefit that particular individual? And then they identify the magnitude of overdiagnosis as ranging between 20% and 50% of screen-detected cancers, which represent overdiagnosis. But then they even say these estimates are based on two imperfect analytic methods. So in discussing this really complicated issue, they identify that there are differing perspectives on what's the right type of evidence to use to judge the prevalence of overdiagnosis, and those estimates range. The NCI says between 20% and 50%, but others argue it could be as low as 1% to as high as 50%. So this is really the crux of my interest in understanding communication around this really complicated context, but I want to overlay that with the social and historical context of breast cancer as well. So this is just a really snapshot into medical sociology and medical historians' views on breast cancer, but just to emphasize that the ideas of breast cancer, survivor identity, the ideas of advocism isn't a word, activism and advocacy around breast cancer that have been a real feature of attention to breast cancer over the last 40 years. As we all know, races and events to raise awareness, both for breast cancer and for the value of early detection. And this context, so this book is from actually a former mentor of mine, Robert Aronowitz, who's a historian at the University of Pennsylvania, who writes eloquently about the history of breast cancer as it evolved from something that, women and their families weren't supposed to talk about. There was a real secrecy around breast cancer, to emerging into this, historically immense lobbying and advocacy effort that brought so much attention and resources to the issue of breast cancer, which he argues has created an inflated sense of fear and personal risk that women deal with around the issue of breast cancer. So what we have then, when women are faced with an individual task of when and what age to get screened, these are really personal, emotional, and value-laden decisions. So what I've shown here is just the screenshot for the kind of patient-focused guidance that the American Cancer Society issued with their update in 2015, and showing the women in age 40 to 44 should have the choice to start annual breast cancer screening with mammograms if they wish to do so. They should have the opportunity to begin screening based on their preferences and their consideration of their trade-offs. So individualizing this issue and arguing for patient-centered decision-making around breast cancer. So I think the sort of last important context I want to add to this consideration before I move into what this study was all about is an issue that has animated me and my work for some time, which is the potential for message backlash. I already hinted at that when I talked about the sugar-sweetened beverage context, but I think important theoretical perspective that is critical when thinking about how people respond to health messaging, whether that be clinical messaging or public health messaging, is this idea of motivated reasoning. And we all have really strong inclinations to hang on to our beliefs. We actually don't like very much to be persuaded when we learn new information. Does that resonate with anyone? Right? So this is particularly true when the new information we're hearing challenges something that's salient to our identity. So an example of this was identified by researchers, health communication researchers, Lieberman and Chaikin, when they talked about how people defensively process health messaging. So I want to tell you a scenario. So there's a new study that just came out, and it tells us that coffee raises your risk for cardiovascular disease. How would you respond to that? Anyone have any reaction to that? Too bad. So you're going to dismiss that study entirely. You're not even going to incorporate it into your belief. Yeah. What else? Anyone else? Okay, so resistance, you don't want to even think about addressing your coffee. Yeah. Anyone else?
Also, how much coffee?
Sure. So started thinking, well, what is this study telling you? How many? Is it really 1 cup? Is it 4 cups? So thinking a little more critically. Yeah. Okay. Yeah. Right. Good. So again, the more that critical thinking. And what is that based on? Where is your criticism coming from? Yes, yeah, exactly. So when there's a behavior, or, you can think about it, the new study comes out around dark chocolate. Or like the one that says dark chocolate's good. That study's great. That has the perfect study design, by the way. Whereas this coffee one, I think the sample size was only 300 people. It wasn't broadly representative. It didn't include individuals who are exactly my age or demographic profile. So yeah, so this idea that we sort of challenge new information that counters something that we hold dear, whether that be coffee consumption or chocolate eating. And what I've shown in some of my work, that political identity is also an important, it's kind of obvious in the political context we're living in this week, or all weeks, that political identity is an important identity factor that strongly challenges how we interpret new information when we hear it. Yeah. So you dismiss just because there's been too many other stories with conflicting messaging. Yeah. Great. So the question that we came to in this work was, what if mammography is that same type of strongly held belief that could lead people to have backlash to messaging. So we were interested because and I say we as a woman, I'm actually 40 right now, just turned 40. We have been told for decades that 40 is when you should start to get screened. We've seen that through pink ribbons and everything. And so this study was really oriented around this idea of to what extent is one's own identification as and mammogram history a source of potential backlash to health messaging in the media. So certainly, our research team is by no means the first to think about these issues as it relates to mammography screening, particularly for women in their 40s. So there's been work around overdiagnosis, the question of overdiagnosis and overtreatment and what that means related to mammography given the sort of values and societal understanding of breast cancer. Others have argued that we need to have more attention to how the media presents this issue, such as in the quote from a JAMA article from 2013 on the left, and Lisa Rosenbaum in a commentary in 2014 digs into these issues not just as communication challenges, but as explicitly ethical challenges and how we balance individual decision-making and preferences, which are at the core of these recommendations that women ought to have the ability to decide when to get screened for breast cancer. The U.S. Preventive Service Task Force indicates that even though they recommend screening at 50, they absolutely suggest that women should consider their values and preferences and consider engaging in screening beginning at 40. And so she questions, how do we balance the need to honor preferences with this public health perspective? So the first stage of this project was really just to look at how often these messages are out there in the news media. So in order to think that these messages have an impact on women, they need to be prevalent, or they need to be at least in the media at some extent for us to be concerned or even empirically questioning whether they have an impact. So we conducted, so my colleague Rebecca Nagler led the study that we published last year in the journal Women's Health Issues, which was a content analysis of local TV news stories about mammogram recommendations across 4 different events of recommendations. So the 2009 U.S. Preventive Service Task Force recommendations. In 2015, there was the American Cancer Society changed recommendation that fall, as well as the draft updated guidance from the U.S. Preventive Service Task Force. And then 2016 in January, there was a revised U.S. Preventive Service Task Force. So we looked at how local television news outlets covered those recommendations. The total sample size for the study was 364 news stories, so we watched 364 video clips of news stories. And one research question that was really important to us was, how often does this get signaled to women as an issue that's controversial or involves conflict? And in about half of news stories did the reporter sort of explicitly frame this issue as controversial, which we think matters from a health communication perspective, because then that is a frame that's overlaid on how women might interpret the guidance that they're learning about. So this slide, I hate to be the one to apologize for a slide that's too small, but I'm in fact doing that. So this is just a graph, a table from the study in which we are trying to understand the prevalence of messages around different types of harms of breast cancer screening or potential risks and different types of benefits. And because these recommendations were described as controversy, these were often framed as arguments for or arguments against the guideline. So these were not neutral news stories by any means describing the guidelines. There was a lot of conflict in how they were presented. But I just want to focus, since I'm trying to orient this presentation around this idea of overdiagnosis. In the 2009 and 2015 cases, we didn't identify any mention of overdiagnosis. It really wasn't part of what we were coding for. We were coding for identification of risk of unnecessary biopsies, which we did see was fairly substantial in coverage. About a third of news stories that we looked at in the 2009, but only 5% in 2015 mentioned unnecessary biopsies. And a small number, so fewer than 10% of the news stories identified this specific language around overdiagnosis. So 4% in 2015 October and 9% in 2016. You can see that arguments around other types of risks of screening, like false positive results, were much more prevalent. Yeah, of course.
What do you characterize as an unnecessary biopsy?
of course.
Or tests that you need. So you can't know if a biopsy is necessary until you get the results.
Yes, no, that's absolutely correct. So any particular individual can't know, but we were looking for the news coverage describing biopsies as unnecessary because that cancer might have been so slow growing that it wouldn't have. So you're absolutely right. From an individual perspective, every biopsy is necessary because it provides clarifying information. But the recommendations themselves that these news reporters are struggling to cover talk about the idea of biopsies that would not have been necessary. It's like challenging beyond words to even explain. But what? Yeah. Yeah.
It's not quite the right term. Because you don't know if you're being overdiagnosed.
Yeah. Yeah. No, overdiagnosis essentially doesn't exist at the individual level. Yep. It's a population concept. So some argue for using the word overdetection. But yeah, this is the crux of it, is just how challenging these concepts are to communicate for individuals. Yeah.
I was going to say the same thing,
Yeah.
because I just want to clarify. So overdiagnosis is evaluation from mammography through biopsy that says you have breast cancer. And we don't know on a population level which
Yep.
of these 100 women that were diagnosed with breast cancer are actually going to have clinically
Correct.
significant breast cancer. And they're going to be treated for something they may not. So it sort of is over treatment, right?
Yep.
It's not overdiagnosis.
Yeah. So the NCI calls it overdiagnosis and resulting treatment.
Right.
So
Because it's not that you're diagnosed with it that's so concerning, it's that you're getting treatment for something that isn't necessary, because the treatment is often worse than the disease.
yeah, I think that's a helpful clarification, and I think is why NCI is trying to put the two concepts together. Oh yeah, of course. So the clarification is that it's not the detection per se, it's the treatment process that someone endures, posing side effects and risks and pain and psychological anxiety and all of that, that would not have been necessary were the science able to identify at this point which breast cancers are so slow growing that they actually wouldn't be lethal. But because we can't, because there is not yet a scientific test or a genetic predisposition or a tumor marker that tells us, right now there's this condition of, from a population perspective, there is some recognition that there's certain proportion of screen-detected cancers represent over-detected or over-diagnosis because of the treatment sequelae. That's not the right word, or I can't pronounce that word, but does that make sense? Does that clarify? Now I have to scoot forward. Okay. All right, so the next stage of the project was a survey that we did in 2016 just to identify women's level of awareness about these very complex issues. So we first asked women to identify how much they were aware of 4 different common messages from media and public health guidance about the value of breast cancer screening. So the idea that mammograms can save lives, lead to earlier treatment of breast cancer, provide peace of mind, find cancer early. And so you can see in that first column that, all the women, basically, were aware of these benefits of screening. So the awareness ranges from 91% to 97% of people who have heard this. So the media, public health campaigns, breast cancer societies, the American Cancer Society have done an amazing job educating women about breast cancer screening benefits. They also think these benefits are very personally important to themselves. On the other hand, these potential harms that are so challenging to communicate and understand, not surprisingly, are less well known by the public in this survey of women age 40 to 59. So this question of overdiagnosis we asked by saying some breast cancers that are found by mammograms are so slow growing that they would not have caused any health problems for women in their lifetime. 25% of women had heard of that. Just above it is this concept of overtreatment, or the sort of treatment. Some breast cancers found by mammograms are treated with potentially risky surgeries or medication that would not have needed such treatment after all. And 40% of women noted they were aware of that idea. Looking at the importance, though, they don't think these potential harms of screening are as important as the benefits. Sort of logically, we weigh benefits I think it's a sort of a psychological phenomenon. We weigh the benefits of something as more important than we do the potential harms. So the last piece of the project, and what I want to focus the remaining time on, is to understand how this, so those were surveys and sort of surveys of the media landscape and surveys of women's attitude, and the next was to understand women's response to messaging about these complicated topics as overdiagnosis. So in order to put together this study, the first thing we did was continue to review news media coverage of mammograms alongside health communication theory to understand what are the different classes of messages that might engage women to think about mammography initiation and frequency. And we identified 3 buckets of messages. There's kind of evidence-based messages around this idea of the sort of the prevalence of overdiagnosis and overtreatment, the medical and psychosocial consequences of screening. Messages in health, sort of broadly in health communication, we can think of norms as being a type of message that shapes people's attitudes and beliefs, of both descriptive norms. So that's the idea that, 5 out of 10 of my friends don't drink, so you understand sort of what is the prevalence of this behavior that I may or may not be engaging in, or some frequency of women choosing not to get a mammogram. The approval of trusted family and friends not to get a mammogram is an injunctive norm. And then stories. So we hear a lot about stories in health communication and in news media coverage. And so in thinking about stories around the U.S. Preventive Service Task Force guidance, these might be stories of physicians and women together making a shared decision, as the U.S. Preventive Service Task Force advises, to not get a screen based on a woman's weight, own personal weight of the potential harms against the potential benefits, or a woman choosing not to be screened based on a friend's experience. And the reason we are orienting around norms and stories in this study is because they're such a natural way of understanding information. So health information or complex information of any kind. Stories and anecdotes are really valuable ways in which people understand a situation that might be otherwise sort of complicated to grasp. And so what I've shown you on the left is a story that appeared in Health Affairs in 2010 to a Health Affairs being a journal for largely a sort of health policy or professional clinical audience. It said, why I don't get mammograms. But that's not a story that is very often discussed in news media. So infrequently in our evaluation, did we ever see such a story in news media coverage? The stories we see in news media more often look like the story on the right here. So this was actually, I just found it from an article in a Canadian online newspaper in 2019 in December. Canada also, like the U.S. Preventive Service Task Force, Canada's major sort of professional guideline also recommends routine screening to be initiated at age 50. And this story says Canada's guidelines say most women in their 40s don't need a mammogram. This breast cancer survivor disagrees. So focusing on the story of the survivor. So the first stage in this study was to do some pre-test analysis of these different types of messages. We did this through recruiting a nationally representative sample of women to read messages in 2017. All respondents read either a typical pro-screening message describing the benefits that I've shown on previous slides, or one of a randomly set of 3 messages describing evidence, norms, and a story, and then answered questions about them. In order to understand response to messaging, we had a few classes of measures that we used to assess women's reaction to them. And these are from communication science measures designed to assess message reactance or resistance. So we talked before about the coffee example, and some of you mentioned, I don't believe this study, or I resist the very notion that this study is real. And so there's measures in communication science to try to assess those types of resistance to information. So measures around whether a message is believable or not, whether it's strong, whether people feel skeptical about it, and I'll talk about those a little bit more. We're also interested in just how people rated the novelty of the messages, and then whether they would support the decision or trust a physician in the scenario of a woman in her 40s deciding not to get screened. So just to show you some results of them, this is the message pre-test. So what I've shown in the colorful bars are the different types of messages that we ask women to read and respond to. The gray bars represent anecdotes. one that described a friend's experience and one that described a conclusion that a woman reached to not get screened at age 44 because of balancing, sort of a doctor-patient conversation and balancing potential harms and benefits. Then we had messages describing the injunctive norms, the idea that friends and family supported a woman's decision, and descriptive norms, that 20% of women know someone who chose not to get a mammogram. And then we had 3 messages describing evidence that were modeled after research studies on the concept of overdiagnosis that had different variants. Some mentioned psychosocial stress, some mentioned the treatment, radiation, chemotherapy, and surgery. And then we varied whether they mentioned cancer explicitly or not. And then we compared them to a message about early detection saving lives, which I'm calling here the sort of pro-screening message. What this figure shows, 2 things. One is that the pro-screening messages was perceived to be significantly more believable than any of the other messages. And the second is that there were no real differences across the other categories of messaging. So there were no major differences between different types of anecdotes, norms, and evidence-based messages. If anything, we see that the norms message and the anecdotes were perceived to be somewhat more believable than the evidence-based messages. We see almost the exact pattern when we ask a different way of measuring this idea of resistance, which is an assessment of or evaluation of how strong respondents perceived that argument to which they were exposed to be, where everyone perceived the pro-screening message to be substantially stronger than these other classes of messages, the anecdote, the norms, and the evidence-based messages. Novelty, the pattern is reversed. So these other messages, these anecdotes, these norms, and these evidence-based messages, we already saw in the news media coverage that they're not very frequent in the news media environment, and in fact, women rated them so. So women rated those messages as more novel, that they hadn't heard them before, than the typical pro-screening message, with the descriptive norms message being the most novel, along with a couple of the evidence messages. So we also looked for any differences in these evaluations of support or trust and found no differences in any of the messages, pro or the messages that were norms, evidence, and stories around initiating screening later, in a woman's decision not to screen or in trust in the doctor. But if you remember from the coffee example, I'm really interested in whether mammogram history might be a source of potential message backlash to these types of messages. And in fact, from this study, we found this to be a very strong predictor of women's response to messages. So women who, in the study, had had a mammogram within the last year, as compared to those who had had a mammogram within 2 years or who had never initiated mammogram, were much less likely to find the evidence message, the norms message, and the anecdote message believable, to identify those messages as strong. And comparing women who had ever initiated mammograms compared to never, and we adjust for age here, so it's not just an age, right? So age and mammogram initiation are really strongly correlated. So to adjust for that, we can adjust for age statistically. We see that mammogram history was related to women's being less likely to support the hypothetical woman in the story's decision not to get a mammogram and less likely to trust a doctor. So from this pre-test, we have some substantial evidence that screening history might be a factor that predicts message resistance. But to test that, we did a survey-based experiment. So we fielded this study in 2009, and it consisted of 2 waves. The first wave of the study was a screener. So we used the NORC, National Survey Organization based at the University of Chicago, and had them recruit a sample of women for us between the ages of 35 and 50, again, to sort of narrow in on this target age range where initiation and frequency are most salient. We then recruited women from the first study to try to get roughly equal numbers of women who had previously had a mammogram and those that had never had a mammogram. They weren't quite equal, so there were 750 who had never been screened and 938 who had ever been screened. And then the women were randomized to receive an experimental message. So we can think in clinical medicine, we talk about experimental treatments. So in here, the treatment is actually just a news vignette that women are asked to read at the start of the online survey. So whether on their phone or on a desktop computer, women taking the survey would first read a little news vignette, and on the next slide I'll show you what that looked like. I just want to describe the study design. So there were 7 treatments, or 7 groups that women were randomized to. One was a news article that described a breast cancer walk and included only information around the value of early detection and screening. Then, as I already described, we had evidence messages, norms messages, and story messages, and we picked the ingredients for those messages, the specific language, based on the pretest. So based on, you saw that there were a couple, option A, option B, option C among evidence, 2 options of norms and 2 options of stories. We took the ones that in the pretest were rated higher on believability to embed in the news articles that women in the study were exposed to. And then the last issue is we're, from a communication perspective, really interested in the differences between messages that are single-sided, that is, only describe one perspective on screening, pro or, I wouldn't say anti, but it's really about limiting or questioning or weighting around screening, or two-sided, stories that explicitly engage with both sort of the positives and negatives of screening. And so the other experimental difference across, besides evidence, norms, and story, was whether that news article was single-sided or two-sided. Before I go on and show you what this looked like and discuss the results, I want to make sure there aren't any questions about the design of the study. Yeah?
Kind of make up the news stories.
Yeah.
They weren't actual news stories of the world.
This is a perfect segue to our made-up news story. So yes, we made them up for reasons where we could control the language and make sure that the language was consistent across. So that way we can ensure that any differences we see are due to our artificially made up. So yes, we made them up, and this is what it looked like. But because we had done the news media content analysis work to sort of systematically read news stories and watch news stories, we had a lot of examples that we drew from to try to make them realistic. Does that make sense?
Media analysis you did earlier on, it wasn't clear to me whether it was TV only or if it was TV, radio.
Yeah. So the published story was only on TV. We had done an analysis of print as well, but not for all 4 time periods. So the data I presented before was on television news stories only. But we had also done some print analysis, but not radio and not social media, which are limitations to what we were able to do, or digital of any kind. Yeah, that's absolutely right. So this was an example of a sort of hypothetical news story that women in the study would have seen. We situated it around an annual breast cancer walk. All of the 7 versions of the news story had the same first paragraph. And then what was different was, and then all of the 6 that were describing norms, evidence, or stories also had the same second paragraph, which identified that recent professional recommendations, so referring to the U.S. Preventive Service Task Force, indicate that women in their 40s with no family history of breast cancer can decide whether or not getting a mammogram is right for them based on their values and perceptions of the potential harms and benefits of screening. And then the story was embedded at the end. You see Rochelle Jones made the choice not to get a mammogram in her 40s. She does not have a family history of breast cancer, and after discussing both the potential benefits and harms of screening, like anxiety and painful biopsies with her doctor, she decided that getting mammograms is not right for her. The two-sided version, so we're interested in sort of one-sidedness and two-sidedness in media communication, where journalists naturally use a two-sided way of communicating. We just added a simple sentence so that's the only difference between these two, which says regular mammograms may help reduce women's risk of dying from breast cancer by catching tumors at their earliest, most treatable stages. And that language was directly pulled from actual news media. So in this study, our outcomes of interest include a qualitative, open-ended response, which we're working on now, to understand women's sort of top-of-head responses to the news coverage. And then we had some closed-ended measures to assess anger, counter-arguing of the information that's communicated, which from previous work and other of my own and as well as other communication scientists are strong indicators of message backlash. So when a message let's go back to the coffee example. If it makes you mad and if you start counter-arguing it, those are indicators that that message is not going to be persuasive to you. So think of that next time you read a news story. If you're starting to feel mad and counter-arguing, those are strong signals of message resistance and potential backlash. We also asked a number of intention items, attitude items, policy opinion items. I'm going to focus here on one specific intention to seek more information about mammogram harm and benefits. So we ended up with 1,689 women in the study who all identified as women. They were aged 35 to 50. 40% were between 35 and 39. 60% were 40 to 50. As we sort of stratified, we wanted roughly equal proportions of women who had and have never had a mammogram. And it was a little more swayed towards those who had ever had a mammogram, resulted because we had more women in their 40s than 30s. And interestingly, we asked about, before beginning this study, discussion of benefits and harms of mammograms. Had a provider ever talked to you about the potential about the potential benefits? And 70% said that they had. 20% had ever heard a provider mention the potential harms of mammograms. And of those, 99% had also heard about the benefits. So we can infer that, a relatively small number of providers of women in this study have been talking to them about potential harms and benefits. So in the next set of slides, I'm going to display these indicators of message resistance, anger and counter-arguing across the different experimental treatments to which women were assigned. So what you see here are the 7 versions of the news vignettes with a little key up on the left. So 1 represents the pro-screening message. 2 and 3 are the evidence and the evidence pro message. 4 and 5 are the norms and the norm pro. So I'm distinguishing the one-sided and the two-sided. And then 6 and 7 is the story and the story with the pro message embedded in it. So what this figure shows is that all the messages made women more angry than did the pro-screening message. So these are all statistically significant differences. So you can see this pattern of response where the evidence message appeared to make women most angry as measured by a scale of negative emotions, where we asked women, how much are you feeling this emotion right now, immediately after reading the message. Then we found that there were the only difference, so we were also testing those paired differences within the same color, so evidence compared to evidence pro, the sort of one-sided, two-sidedness. And the only significant differences between the pair was that the evidence message, without the recognition of the message that mammograms save lives, made people significantly more angry than did the two-sided message. So the counter-arguing, so this is a scale made up of how skeptical did you feel when you were reading this message, how much did you counter-argue the claim. So again, the example that we went through with coffee, we see significantly more counter-arguing in response to each of the evidence, norms, and story as compared to the message 1 on the graph, which was the pro-screening message. But we did see some differences where there was more counter-arguing, significantly more counter-arguing for the plain story message about Rochelle as compared to the story message that it included the pro-screening message in it. So remember, we're really interested in whether response to messaging, anger and counter-arguing, might differ based on women's own mammogram history. So the next slide is going to plot those same responses, but for women who had ever had a mammogram, and they're in red. So the yes mammogram is the line of the 60% of women who had ever had a mammogram compared to the 45 or whatever percent of who had never had a mammogram in this study. And what this tells you, those lines are almost exactly the same, right? So you see a very similar pattern between women who had a mammogram and women who did not have a mammogram, meaning that there was no interaction. So there was no conditional relationship between reading the news media and having a response to it based on whether the individual reading that media clip had ever had a mammogram or not. So respondents were equally frustrated, equally made mad by the messages, and equally counter-argued whether or not they had had a mammogram, but the level of anger response was higher for women who had a mammogram. So that's demonstrated by the fact that the red line is above the blue line in all 7 of the experimental groups. So then I said that the sort of last measure that we're interested in is whether after reading the news article, we asked, how likely are you, the individual survey respondent, to talk to your doctor next time you have an appointment about harms and benefits of mammograms? So we're interested in whether these news media messages might spur action. What we found, this pattern is a little strange to see, but what it shows is that there weren't that many differences, so statistically significant differences. So these dots represent the means, and then the confidence intervals are the bars above and below. Across the 7 experimental groups and who was likely to go talk to their doctor about them, the only ones that were different was that the evidence pro, or the 2-sided evidence message, and the story pro were both higher than the control group, or the pro-screening message, which is, we're considering the control in this study, which means that something about the 2-sided evidence message and something about the story pro message, so 3 and 7, indicated to women that they might want to talk to their doctor more. So now it's the same chart, but plotted for women who had a mammogram and had not had a mammogram, and the pattern is really weird, but there is no pattern here. There were no statistically significant differences across women who had had a mammogram before and those that had not. So all of those confidence intervals overlap in statistical terms. So we also looked at a few other outcomes. So we asked women, I'm a health policy person, so I asked about policy. I asked about insurance coverage. How much do you think insurers should cover mammograms? How much should providers be recommended to offer mammograms? And there were no differences in any of these kind of policy. So the real differences were more of these emotional reactions and interpretation of the messages, not more sort of bigger picture policy-related attitudes and beliefs after reading these news media messages. And that's fairly consistent with other media effects studies where we might see differences in a more transient reaction to a message, but maybe not in someone's broader perspective on policy or guidelines in general. But we do see these striking negative responses to the media messages about professional recommendations to delay screening until 50. This was for women with and without a mammogram history. And some tentative evidence, if you squint along with me, about the 2-sided messages being potentially more persuasive and arousing less negativity than a 1-sided message. Consistent with kind of norms of balanced journalism. So most news reports do cover both sides for a lot of issues. And I would argue editorially for good or bad, right? Sometimes there is no 2 sides to an issue. But we're also working on ongoing qualitative analysis to help understand these mechanisms with more nuance. So I wanted to conclude, and I hope for lots of discussion from you all on some ethical implications and future directions. So this work, considered from the news media piece, the public awareness measurement, and finally this messaging experiments, tells me from a public health perspective that policy efforts and communication around this complicated, politically charged, and value-laden concept of overdiagnosis needs to recognize that beliefs about screening are strong and that there's a likelihood of backlash being triggered. We've already talked today about how challenging it is to communicate this concept of overdiagnosis, which really only has meaning at a population or aggregate level and not at an individual level. So like any good researcher, I want to argue that more evidence-based communication strategies are required to understand how to emphasize women's autonomy for decision-making in light of this social context surrounding breast cancer screening, identify ways to talk about other types of de-adoption of valued health services. So from a public health or health policy perspective, we learn every day about medical treatments, screening, preventive care, that we later learn to not have this value that we thought it once had. And communicating about how to let go of something that has value that people experience as an important part of their medical care routine. So communication about de-adoption is just as important as communicating about adopting healthy behavior. And so I think there's a lot of work to be done at this intersection of, as evidence changes, as we learn more about what we are doing in medical care that doesn't have value or poses more side effects than it does benefit, there needs to be more attention to these communication-related issues. That women's strong attachment to screening routines and the value of screening may challenge acceptance of new information, like when the U.S. Preventive Service Task Force issues new guidelines. And the other piece is that we don't see strong evidence that evidence, stories, and norms, that one or the other is better. We see maybe that women in this study didn't really like the evidence-based message, but that demands kind of future research to explore. And I also want to close with what I think is really essential needed research. Our study was a nationally representative population, so we did not oversample for women of color or women who are otherwise medically underserved. But that's those are extremely important populations to consider in better understanding attitudes and beliefs about overscreening, overdiagnosis, and medical care in general. So that's, I think, an important priority for the future. So, ready for questions?
So if you have a question, I'm going to ask you to use the mic.
Is it on? Thanks. So do you see the rate of women that are foregoing screening, is that increasing in populations where they're expressing their autonomy and they're making a decision that really was just fine, or do you see an increase in the number of women that decline screening and later on it was found that they did have breast cancer and they should have gotten a screening? So do you, with this sort of drive to you can forego this screening at 40, is that impacting populations that should have gotten screened, or that really they made a good decision for themselves?
Yeah, so I can't answer that question specifically. There's a lot of health services research looking at whether overall population patterns of screening initiation and frequency have changed. My take is that there are small decreases since the 2009 recommendation around delaying screening until 50, but that depends on a lot of factors. It depends on lots of characteristics of women, and it depends on where they seek care. So we're seeing that there's different practice patterns depending on physicians, where screening initiation differs whether you, and I say you meaning a woman in her 40s, gets screened through a family practice or primary care versus breast oncology. It's sort of the entry of care that looks like it matters for the population who are screening at 40 versus 45 versus 50. And so there's some really interesting work looking at those practice pattern differences as well as the clinician recommendation differences. But I can't speak to sort of everything in that work. It's really not what I do as a communication person. So though you're raising really important questions that unfortunately I can't answer too satisfactorily right now. Sorry.
I want to understand better how harm is being defined and framed. I think in one of the slides it said, the risk of a false positive and anxiety about that, and then something about painful biopsies. And as someone who is a survivor and did a lot of research before I got my surgery and care, understanding that the likelihood of a false positive is high can change your framework around how anxious you are about the result. So I think there's an issue around health communication in terms of people understanding better about the prevalence of false positives. Yeah. And in terms of biopsies being painful, they're not super painful. They're kind of annoying, but
yep.
They're they're definitely dealable. So how are you framing harm, or how is harm being defined in the context of this study and in the field more broadly?
Yeah, so I guess the best response to that is just going back to what we did when we culled news media. So these were the major, I guess I don't have the specific definitions. So our research assistants were watching and reading news media and then identifying how news media were framing these different harms. And what's on the top of the screen represented the most frequently discussed or framed harms in news media. So identifying anxiety, false positives, we didn't look at the sort of language around the magnitudes, which I think is what you're getting at, sort of how bad is it? And so I can't, yeah, yeah,
Yeah, it doesn't have to be alarmed. If you understand,
Yeah.
oh, I'm being called back in for another diagnostic mammogram, but the chance of it being something is actually pretty low,
yeah.
then maybe you don't have to feel so anxious about it, or you can put that situation in a frame or in some kind of context.
I think that's exactly right. I agree with you, and I think that's where the sort of clinician-oriented communication is such an important part of the story that I'm unfortunately not getting in this analysis of how the news media are talking about it, because the news media may be saying one thing, but what actually matters for women like yourself is how a clinician is describing what these mean. So I really appreciate your comment.
I was going to say in response to that, I think it also has to do with what you talked about at the very beginning by how the media is portraying breast cancer, and how, that it is prevalent in hearing about it and hearing people's stories and seeing about it, and so died of breast cancer, that I think while people understand that there's a lot of false positives and therefore I shouldn't be anxious, everyone's anxious about getting breast cancer. And I think the media does have a lot to do with that. So I think it's kind of a self-fulfilling prophecy in many ways. And my other thought was, when you asked, only 20% of the women had said that they had heard of the harms when they discussed it with their doctor. I think that's really interesting, because I wonder, when physicians are talking to patients about screening, that is a nationally accepted standard. So let's take away the 40 to 45 age group, because that's still up in the air, but a 55-year-old woman, so she should be getting screened for breast cancer. I think there's a lot of concern that in our current climate, raising any potential harms can be taken so far out of context that people would decide to choose to not get screened. So I just think that's interesting, because I'm in that 20%. I'm a physician, so I probably don't get as much information as other people, but nobody's ever talked to me about, quite honestly, I never heard about overdiagnosis until I came here today. I knew about false positives, but the idea that there are some percentage of women diagnosed with breast cancer who are getting treated for something that would never have led to their death is really interesting. But I think it's that worry that if you talk about the harms of something that really essentially everyone probably should do, then you get some percentage of people that say, nope, I'm opting out. If there's any risk of harm, I'm not going to do it.
No, absolutely. I hate to bring in another controversial and politically loaded topic, but the vaccine cases, you can think of a lot of connections where you don't want to identify. There is so much skepticism and hesitation that when talking about potential side effects, that can become experienced by a person as something bigger than it really is, given the social, political, cultural context around vaccines today. So I really appreciate your comments.
I know that you've already mentioned that you're not able to speak to the clinical conversations that we have with our physicians, but I think it's really important that you're looking at how women learn from the media about these issues in the context of the fact that I know I'm just an N of one, but I get really clear and direct and insistent messages from my physician, from my primary care physician. You're due for your mammogram. You're overdue for your mammogram. Why haven't you scheduled your mammogram? And nothing else. And I am a regular consumer of preventative care who's well-informed and well-educated. But to look at only the way we are affected by media reports without addressing the way that physicians are trained to tell their patients what to do seems to be missing a huge part of how we are affected by this information.
No, thank you for that comment. And I understand in a potential study that we have a grant under review, I'm working with a team at Johns Hopkins where we're looking more at the health system context around messaging. So I hope to be able to engage with that side soon. It just hasn't been what I've looked at to date. So thank you.
I understand you can only do as much as you can do one step at a time.
Hi, I just wanted to ask if you could provide a little bit more clarity.
Sure.
I think it may have been the last slide, and you kind of mentioned a little bit about underserved populations and
Yeah.
more needed research. So does that indicate that the study did not include underserved populations, or did it include?
Yeah, very happy to explain. So this study was a representative sample of American women between the ages of 35 and 50. And of that, 70% identified as white, 30% identified as other racial and ethnic groups. There was we didn't specifically study women of color or women with lower income. So although we had women of lower income and women of color in the study, we didn't have enough numbers to be able to look at whether the responses to media were different among people of those different sort of demographic or social identities. Does that make sense? So another study that might recruit a different sample might have more information on whether there are differences across groups, and that just wasn't the way we collected this information, and it's super important to do in the future, in the next study.
I think it is very important, considering
Thank you.
that if you're going to have a study, how the data is collected,
Yeah.
and if your audience, you don't have an audience that proper represents the population that you're treating,
Yeah.
that the information could be inaccurate.
Yeah.
Happen to be an African American and dealing with people from diverse backgrounds, even the media, if a person can't relate to someone who's conveying a message, they may not receive it.
Absolutely.
Honestly,
Absolutely.
it's just the way it is. So, just a
Yeah,
little
thank you
concern.
so much. I agree with everything you said. Yeah, and this study was using a survey research firm with sort of we did not recruit as we would have were we to focus on different subpopulations, and so that's a future priority in the next grant, next project. Thank you.
I kind of had a segue question from hers, just with the needed research. So I don't know if you have the answer to this, but do you have trends or observations about what you are seeing in the underserved populations, or how women of color or women that are foreign-born, what's their experience? Are they getting screenings done, or are they rejecting that notion? And, the difference between, like, they might not have that Western medicine mindset and such. I don't know if you have any thoughts on that.
My colleague Rebecca Nagler is in the School of Journalism. She did focus group studies with immigrant women in the Twin Cities around breast cancer screening. And again, I wasn't on that study, so it's hard for me to totally generalize her conclusions, but she found that most of the women in her focus groups were not aware, were aware of recommendations for women in their 40s and were initiating screening.